There's several different types of ventilator control modes that are out there, and we're just going to review how each one of these works. Now, when we talk about a ventilator control mode, what we're talking about is what makes the ventilator start breathing. Remember we said that when we talked about volume targeting and pressure targeting, we said that's what makes the ventilator stop blowing? Well, the ventilatory control mode is what makes the ventilator start blowing. And so let's talk about the most simplistic type of ventilatory control mode, and that's control mandatory ventilation. In control mandatory ventilation, it's exactly what it sounds like. You have absolute control of the patient's ventilation. You have control of their tidal volume. You have control of their rate. So when we put a patient in a control mandatory ventilation, a true control mandatory ventilation, we have completely bought responsibility for that system. We have now said you're going to get X number of breaths at X amount of volume or X amount of pressure a minute, and that's it, period, end of story. And in true control mode, the patient doesn't even have the ability to take other breaths. If they try and take a breath in a true control mode, then they're just breathing against a closed circuit. They're suffocating because they're not going to get any breaths until the ventilator says it's time. So, control mandatory ventilation, for the most part, is an archaic type of ventilation. Most places don't use this anymore, and there are a couple of very small exceptions. One exception of a place where we may actually use control mandatory ventilation is in the patient who needs inverse ratio ventilation. Because inverse ratio ventilation is not intrinsic. It's not normal for us to inhale for 3 seconds, exhale for 1, and then inhale for 3 seconds, exhale for 1. That's not normal. That's not the way we breathe. We normally have 1 part inspiration for anywhere from 2 to 3 parts expiration. So when I'm taking somebody and I'm purposely flipping that, when somebody's in hypoxic respiratory failure, and I'm at the point where I've got to start thinking about inverse ratio ventilation, a lot of times we will put them into a control mode so that we do take over their respirations because we don't have any choice but to control them. Now, having said that, the big thing you need to know about control mandatory ventilation is that in order to safely use control mandatory ventilation, your patient must be absolutely, positively schnockered. They must be deeply, deeply sedated. The patient must get adequate pain medicine. And the other thing is, most of the time, this is a patient who does have to be paralyzed, because they're not going to find it comfortable. They're not going to sync with the vent if we've taken total control. Now, again, with the exception of a few types of things like what we talked about, the inverse ratio ventilation, for the most part, we don't use control mandatory ventilation anymore because it's basically a pretty archaic, pretty cruel way of ventilating patients unless we keep them completely snowed. Now, assist control is a mode of ventilation that's still used a lot. We use assist control for lots and lots of things. And when we talk about assist control, the first thing you need to know about assist control is it's just like control ventilation in that you're still going to have a minimum number of breaths in a minute, and you're still going to set a minimum tidal volume if you're volume ventilating, or you're still going to set a minimum PIP if you're pressure ventilating. But the thing that's different about assist control is the patient can actually take a breath whenever they want. The ventilator is going to deliver its breath. So let's say that you've set it on 10 breaths a minute. So once every 6 seconds, that ventilator is going to give a breath. Psh, psh, every 6 seconds on the clock. So that's a good thing. But the patient can also take a breath whenever they want. So if you get a breath at second number 1, you get a breath at second number 6, and then let's say second number 8, the patient says, hey, I want another breath. Well, at second number 8, the patient can do that. They can take a breath. But here's the catch with assist control. Every single time the patient takes a breath, they are going to get a full-on ventilator breath. So whatever tidal volume you've set if you're volume ventilating, or whatever PIP you've set if you're pressure ventilating, every time they take a breath, they're going to get the full-on breath. They're going to get a full-on tidal volume breath. So they have the ability to control their rate, but they don't have the ability to control their volume. Okay, so who would be a good candidate for assist control? Why would we use it? Well, for the most part, most people actually tolerate assist control fairly decently as long as we've appropriately set our flow and all that other good stuff. For those patients, the big advantage is that they, again, can take a breath whenever they want, and they're going to get the work of the ventilator with each breath. Now, when we talk about the ideal patient for assist control, probably the ideal patient is somebody who has the physiologic ability to take a breath in every way but they don't have the strength. So what in the world does that mean? That means their chemoreceptors are doing what they're supposed to. That means their nervous system is doing what they're supposed to. The only thing is the diaphragm and the intercostal muscles just don't have the strength to pull it off. So we use this a lot in people who are just plain tired. Like your patients who've got exacerbations of COPD and they've been huffing and puffing trying to breathe out for so many days that now they don't even have the ability to breathe in, and so they're in respiratory failure. The other place where we'll use this a lot is in people who have neuromuscular diseases that prevent them from having the strength. So for instance, we might use this like for a patient who's got like an exacerbation of myasthenia gravis, where they have the ability to breathe mentally, they have the neurosystem telling them they need to breathe, it's just the muscles just don't have the oomph to make it happen. So for those patients, assist control is an ideal mode. Now, the one thing you do want to be cognizant about with assist control is that the ventilator is going to give its number of breaths at the preset rates that we've set. So if the patient is over-breathing the ventilator, we want to make sure that our preset breaths are far enough apart that we're not stepping on the patient's intrinsic breaths. Because if we're stepping on the patient's intrinsic breaths, then we could actually end up with ventilator stacking, which is where like I take a breath as the patient, get a full-on ventilator breath because we're in assist control, and before I've even had a chance to exhale it, the ventilator goes, oh, yep, it's time to give another breath, and slams another breath in. So I get twice the tidal volume, and obviously that leads to significant volume trauma and barotrauma. Okay, the next evolution in ventilator management is actually something called IMV, or intermittent mandatory ventilation. Now with intermittent mandatory ventilation, you've still got a baseline rate and you've still got a baseline tidal volume if you're volume ventilating, or a baseline pressure if you're pressure ventilating. But what's different about IMV is that, like assist control, the patient can take a breath whenever they want. But the thing that's different about IMV from assist control is that when the patient takes a breath, they are essentially taking it on their own. The ventilator is not giving them a full-on ventilator breath. So to take that and make that concrete again, make sure that we're on the same piece of paper. When I put a patient into assist control, there's a baseline tidal volume, baseline rate. But the patient can take a breath whenever they want, but every breath is a full-on ventilator breath. In IMV, still have a baseline rate, still have a baseline tidal volume, and the patient's going to get that number of breaths a minute at that tidal volume, plus the patient can take a breath whenever they want, but that breath is essentially unassisted. The ventilator really doesn't do anything. The ventilator says, okay, have at it, you can take your breaths whenever you want. Now, I'm still going to give my breaths, and so the problem with intermittent mandatory ventilation is that you basically have two things that are working in tandem that are having no communication. Because the patient's going to take breaths when they want, and the ventilator is going to take breaths, or the ventilator is going to give breaths when it wants, but there's no overlinking of the two. And so we end up again with issues like stacking and things like that, because if the patient decides, I want to take a breath now, and they take a breath, and the ventilator goes, oh, it's time to give a breath, and psh, gives another breath, then I've just stacked one breath on top of another, and again, I've just hyperinflated the patient. Now, lucky for us, IMV is also one of those things that doesn't exist a lot anymore. Most of the ventilators now that you see that are even labeled as IMV are actually not IMV. Most of your ventilators now are actually something called SIMV. So what is SIMV? SIMV is synchronized IMV, synchronized intermittent mandatory ventilation. So what does SIMV entail? Well, like all the other methods, you've still got a baseline rate, you've still got a baseline tidal volume if you're volume ventilating, or you've got a baseline PIP if you're pressure ventilating. But with synchronized intermittent mandatory ventilation, the patient still has the ability to take a spontaneous breath whenever they want. So what's the difference between SIMV and IMV? The synchronization. With SIMV, the ventilator actually is designed with a computer circuit that basically puts a little window in front of every ventilator breath. And that window depends, how wide that window is, depends on how long it is between breaths. So for instance, let's say I've got the ventilator set to give 10 breaths a minute. So that would be one breath every 6 seconds. So inhale, 2, 3, 4, 5, 6. Inhale, 2, 3, 4, 5, 6. Well, with IMV, remember the patient could take breaths whenever they wanted, but the ventilator wasn't paying attention. It said, you can take a breath whenever you want, but I'm going to do my thing. With SIMV, because there's a window in front of each ventilator-driven breath, what the ventilator does in that window of time is it says, I'm going to look before I give my breath. And if the patient starts to take a breath inside this window, then I'm just going to go ahead and give him the ventilator breath. So for instance, let's look at our window again. Let's say we had 6 seconds. So I get a breath at second number 1. Nothing happens for 2, 3, 4, 5, 6. And then I get another breath at second number 1 with the next cycle. Well, if the window was, say, 1 second wide, then if the patient gets their ventilator breath at 1 second, nothing happens at 2, nothing happens at 3, nothing happens at 4, nothing happens at 5. But at second number 6, the patient says, I want a breath, and they start to take a breath. Instead of the ventilator giving a breath on the next second, the ventilator, because the breath was taken in that window, says, oh, he's taking a breath now, so I'll just give him my breath now. And so the patient actually gets a full-on ventilator breath. Well, what happens if the patient wants to breathe outside that window? We said the window was a second long, so let's say instead of the patient wanting to take a breath at second number 6, let's say the patient wanted to take a breath at second number 3. Well, because that's far enough away from both breaths, it's not inside the window, so in that case, the patient takes whatever breath they want, and the ventilator does nothing to help them, nothing to hurt them. So this is by and far probably the most common used ventilator method in critical care today, at least in the U.S. Most patients nowadays are ventilated with SIMV. It's the most physiologic, it's the most comfortable, it's the most advantageous. So again, if a patient tries to take a spontaneous breath outside the window, then the patient can take whatever breath they want on their terms. The ventilator does nothing to help them, nothing to hurt them. If the patient tries to take a ventilator breath inside the window, then when they take their breath inside the window, the ventilator syncs with the patient and gives them the ventilator breath at the appropriate time. Okay, so those are the ventilatory control modes. The other two things that you need to know about is you need to know about ventilatory support modes. Now, these are things that we do in addition to one of the previous modes that we already talked about. So, when we put a patient on assist control, or we put them on SIMV, or we put them even on control, these are modes that we can add in addition. The first thing that we can add is we can add PEEP, and we've already talked about what PEEP is. We know that PEEP is the inability to completely exhale, and we said that the reason why we would put somebody on PEEP is to improve their oxygenation. We would do that to improve their mean airway pressure. Now remember that PEEP doesn't do anything to the rest of the ventilatory cycle, meaning that assist control or SIMV or control is still going to work the same. The only difference is if we look at the respiratory waveform, the patient is not going to completely be allowed to exhale. The other type of support mode that we use very commonly is we use actually something called pressure support. Now, what is pressure support? Pressure support is something that we only use in SIMV. And the reason why we use pressure support is to make it easier for the patient to take those spontaneous breaths that are outside the window. So remember with SIMV, we said there was 2 kinds of patient-driven breaths. There was a breath inside the window, and if they were inside the window, then the ventilator just says, oh, you're taking a breath, so here's your full-on breath. In contrast, if there were breaths outside the window, we said that the ventilator was not going to give a full-on ventilator breath. Well, with pressure support, what we do is we actually have kind of a halfway in the middle kind of thing. That's probably the best way to describe it. When a patient takes a breath outside the window in SIMV and we've got pressure support on, what the ventilator is going to do is as the patient starts to inhale, the ventilator is going to blow. But it's not going to blow a breath. It doesn't blow a full-on breath like it would if the breath was inside the window or if it was one of the ventilator-driven breaths. Instead, what the ventilator does is it just gives a little bit of flow. So instead of giving a full-on ventilator breath, instead what it does is it gives just a little bit of support. So why would we use pressure support? Well, the big reason we use pressure support is because if you sit and try and breathe through an ET tube for any length of time, you find out that it's pretty freaking tiring pretty freaking quickly. It's really hard to breathe in and out of an ET tube. That's not intrinsic. We're used to having a fairly big trachea, a nice big mouth and nose, and breathing in and out through this long tube is taxing. So when we put somebody on pressure support, basically what we're doing is we're adding just a little bit of flow only when they breathe in. So only when they start to inhale, and it's a breath that's not inside the window for a full-on ventilator breath, then what we do is we give just a little bit of flow. And by doing that, it makes it easier for the patient to be able to inhale. So basically all we're doing is overcoming the negative resistance of the airway circuit. Now to conceptualize, if I'm pressure ventilating somebody in assist control, when I'm giving a full-on pressure breath, a lot of times I'm using pressures of anywhere from 20 to 30 centimeters of water. So I'm using fairly high pressures to push that breath in. When I put a patient on pressure support, a lot of times I'm only using like somewhere between 5 and 10 centimeters of water. So I'm using somewhere between like a fourth and even as small as a sixth the amount of pressure that I would be giving if I was giving the patient a full-on ventilator breath. And if you have a patient who is in SIMV and the patient is spontaneously breathing, if they're not if they're not paralyzed for some reason, if that patient is being allowed to overbreathe the ventilator, which is what we should be doing if we're using the ventilator appropriately, then every time a patient is in SIMV, they should also be getting some pressure support. Because otherwise, you almost always will get bucking of the vent. Because the patient, when they want to take their breaths that are outside the little window, they're trying to breathe through this stupid ET tube, so they're like, ooh, it's really hard for them to do. If we put them on pressure support, if we give them a little bit of to overcome the resistance of that ET tube, lo and behold, it is much, much easier for that patient to breathe. Okay, a couple other modes that you need to be familiar with, just a couple other ventilator things that you need to know about. You need to know what airway pressure release ventilation is. Airway pressure release ventilation is a type of ventilation that we use for patients that are so sick that we can't improve their mean airway pressure by any other means. So what does that mean? So that means that we would use this in the patient who's got hypoxic respiratory failure, and we have been unable to get an adequate mean airway pressure to get enough oxygenation despite the fact we've put them on PEEP, despite the fact we've increased the PEEP, despite the fact we've increased the inspiratory time, and we've even eventually inversed the IE ratio. When we get to the point where we're talking about inversing the IE ratio, a lot of times what we'll do instead is we'll put this patient onto airway pressure release ventilation. And the easiest way to conceptualize airway pressure release ventilation is it's just 2 levels of CPAP. So you've got a first level of CPAP that's really high. So we put them on CPAP at like 20 centimeters, 25 centimeters of water. So the patient is getting this continuous flow of air, just and that continuous flow is keeping their lungs inflated. Now, we said there was 2 levels. At predetermined intervals, that flow is going to shut off or shut down for just a very short period of time. And when I say a very short period of time, I'm usually talking about like 1 second. So basically what we do is we keep the patient on constant high levels of CPAP. So let's say we've got the CPAP continuously running at 20 centimeters of water. So we're blowing lots and lots of air down into this patient's chest. Because it's CPAP, they still have the ability to breathe over that as much as they want. They can breathe 10 times a minute. They can breathe 200 times a minute. They can do whatever they want. But at predetermined periods, like out of every 4 seconds, we will drop that CPAP down for 1 second. So we're blowing along for 3 seconds. Then we drop it down. Then we're right back up. Then we drop it down. Then we're right back up. So the CPAP has nothing to do with the patient's spontaneous breaths. They take as many or as little as they want. What we're really giving them here is just those 2 levels of CPAP, the high level and the low level. And this is not the same thing as BiPAP. And we're going to talk about BiPAP a little bit later, but BiPAP is something very different. When we put a patient on BiPAP, what we're doing is we're actually putting them also on 2 levels of ventilation, but one of those levels is only triggered by them taking a breath. So for instance, when you're on BiPAP, I may have you on a continuous PEEP of say 5, but then when you try and take a breath, I put you on another 5. So now you're on 10 while you're breathing in. Another way to conceptualize this, the easiest way to describe BiPAP is just pressure support plus PEEP. When we take a patient, we put them on PEEP, and we add pressure support, that's BiPAP. Airway pressure release ventilation is very different because in airway pressure release ventilation, while we still have two levels, those levels are not driven by the patient's breaths. It's completely independent of the patient's breaths. We go high, 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 low for just a second, high, 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 low for just a second. Well, by doing that, what we've done is we've essentially created inverse ratio ventilation. And that allows for us to dramatically increase the patient's mean airway pressure. But the cost of those little drops in PEEP, where we just drop it for just a fraction of a second, is that the patient's CO2 is also going to climb. So we use airway pressure release ventilation typically for patients who have severe ARDS, severe hypoxic respiratory failure that's refractory to other things like I said before, like adding just regular PEEP or just adding inspiratory time or adding oxygen or those types of things. Okay, the other type of ventilation that we occasionally use in adults, that we don't use a lot in adults, we use a lot more in kids, but we're seeing more and more of it used in adults, is oscillation. Now, when we talk about oscillation, the way that oscillation works is completely different from every other type of ventilation that you're familiar with. First off, with oscillation, there is no such thing as a tidal volume. When we talk about oscillation, the way that it works is we're actually going to give a certain amount of volume of air, but it's not a tidal volume because it's not enough to make the patient have a breath. In fact, usually when we're oscillating, we're only giving about as much air as in the patient's dead space. So basically however much air is in their trachea and their big bronchi. So we're giving this little volume of air, which for an adult may only be, say, 70 or 80 cc's. But what we're doing is instead of giving that breath once every 5 seconds or once every however many seconds like we would with regular ventilation, instead what we're doing is we're shooting that breath in and out. We're actually moving that air in and out. And with the oscillator, not only are we blowing air in, we're sucking air out. There's actually a piston that's moving air back and forth in and out. And that movement of air in and out actually occurs at least once per second. So the very slowest that we could set an oscillator at is what we call 60 hertz. A hertz is how many breaths are in a second. And so the slowest we would set an oscillator at is 60 hertz, 60 breaths a minute. So 60 times a minute this is moving back and forth. Now, most of the time when we use an oscillator, we don't use it at 60 hertz. Instead, what we usually do is we use it at like somewhere between 300 and 500 hertz. So that means that patient is getting anywhere from 2 to as high as 7 or 8 breaths a second. Anywhere from 2 to 8 breaths a second. So that's constantly moving. Now, when we talk about using an oscillator, you have to understand just a couple of basic things about the oscillator. Remember, again, we said we're not using a tidal volume because we're not giving enough volume to actually be able to make the lungs open and close. Instead, we're just giving enough air to basically just move back and forth. And the way that we think oscillation works is by moving back and forth, it constantly makes all the air in the lungs move around. It's like constantly agitating things. It's like almost like taking soap and putting it into a container of fluid and shaking it up. And by doing that, we're allowing for better diffusion of gas across the lungs. Now, when we talk about that volume that we're moving back and forth, we actually call that the amplitude. The amplitude is how much air is moving back and forth with each one of those little tiny tidal volumes or breaths, for lack of a better thing to call them. And then the other thing that we use is again the number of hertz, the number of breaths that are being given in a second. Now, the way that we control the patient's CO2 is with those two things. We control their CO2 with the number of hertz and with the amplitude. So in other words, how much of that little tiny air are we moving? Are we moving, say, 70 cc's or 90 cc's? And how many times a minute are we doing it? The faster we do it, the bigger the breath, the more CO2 we remove. Now, when we control the oxygen, we actually control the oxygen with the FiO2 and with the mean airway pressure. And the oscillator is designed so that it always maintains a pressure in the lungs. And that mean airway pressure, just like with all of our other modes of ventilation, the higher the mean airway pressure, the better we oxygenate. The lower the mean airway pressure, the less we oxygenate. So that's really how an oscillator works. Okay, so when we go back to our regular respiratory parameters, just a couple of quick things here, just some recall type things for you to remember. Remember that a normal minute volume using a standard ventilator for an adult is usually somewhere around 4 to 8 liters a minute. When we talk about tidal volumes, a good acceptable tidal volume range is somewhere in the range of 6 to 10 cc's per kilo. And remember that all that is a ballpark. If you put a patient on 6 cc's and it's too much, you need to go down on the tidal volume. If you put a patient on 10 cc's and it's not enough, you need to go up on the tidal volume. When we talk about an acceptable rate range for an adult, an acceptable rate range is usually like anywhere between 8 and 20. When we talk about the IE ratio for an adult for normal regular ventilation, usually we put adults on an IE ratio of like 1 to 2 to 1 to 3. So that means 1 part inspiration for 2 parts to 3 parts exhalation. When we talk about oxygen concentrations, obviously we can use anywhere from 0.21, which is room air, 21%, all the way up to 1.0, which is 100%. And remember that the big focus in critical care, if we're going to have the patient on the ventilator for any length of time, is we certainly want to get them down below 50% as quickly as we can while still maintaining a good oxygen saturation. Remember we said about the plateau pressure that we always want to keep the plateau pressure less than 30. Remember that when we have plateau pressures greater than 30, that dramatically increases the chances the patient's going to get ARDS and acute lung injury. And finally, the big thing to remember about ventilator synchrony, especially if you're using your ventilator appropriately and allowing your patient the ability to spontaneously breathe, is that we always want to make sure there's an adequate flow. We want to make sure that the flow is enough that the patient can easily, comfortably take a breath when they want. And so generally we say that a flow of anything less than 40 is unacceptable. In fact, respiratory therapists will tell you that when we put a patient on a flow less than 40 liters a minute, this is for an adult, that's considered like cruel and unusual punishment. So we definitely want the flow to be at least 40 liters a minute, and most of the time we really want the flow to be somewhere in the neighborhood of about 60 liters a minute. 60 liters a minute is usually a pretty good flow for most adults. Now, when we talk about the flow, remember that the faster the flow is, the more that's going to change your IE ratio. So for instance, if I take a flow and I make it faster, that means that my inspiratory time is going to be less because I'm putting in the same amount of air in a shorter period of time. Therefore, my expiratory time is going to be longer. If you have your choice between having a perfect IE ratio of 1 to 2 or 1 to 3 or having an adequate flow, the right answer is you want an adequate flow. That is more important than the IE ratio. And this is a really important point to understand when we talk about transport ventilators. A lot of your transport ventilators, the IE ratio is completely dependent on the flow. For those patients, you definitely want to make sure that if they're not paralyzed, if they're being allowed to breathe on their own, that you have enough flow for them to breathe successfully. What that usually means is that what's going to happen is your IE ratio is going to become like 1 to 5, 1 to 6 instead of 1 to 2, 1 to 3. Who cares about that? If your patient is being allowed to breathe, the flow being adequate is much more important than the IE ratio being nice and pretty. Okay, when we talk about troubleshooting the ventilator, just a couple of quick things here. When we talk about troubleshooting, what do we do if we've got a high pressure alarm? Well, remember with a high pressure alarm, there's lots of little acronyms out there. Some people use SCOPE, some people use DOPE. But the big thing with a high pressure alarm is recognizing that a high pressure alarm is always an emergency until proven otherwise. Anytime we have a high pressure alarm, it's an emergency until proven otherwise. So as soon as we identify the patient has a high pressure alarm, a high peak inspiratory pressure alarm, what we need to do is quickly go through and find out if there's any one of several life-threatening things that are causing that high pressure alarm. Now, one of the things that could definitely cause a high pressure alarm that could be life-threatening is if the ET tube has become obstructed or if the airway has become obstructed. So the first thing we probably need to do is suction the patient. By running a suction catheter all the way down the ET tube, we verify that the ET tube itself is patent and also that there's not something in the airway. The next thing that we want to do is we want to check all of our connections and make sure that our connections are appropriate, that our connections aren't blocked by anything or that our connections aren't in the wrong places. We want to make sure that there's not any obstructions, again, in the ET tube or in the airway. We want to make sure the patient doesn't have a pneumothorax. And finally, the last thing that we want to do is we do a quick scope assessment is we want to make sure that the patient's ET tube is not dislodged or displaced. Now, if we have a patient who's dislodged their ET tube, let's say that it's at a different depth than what it was before, let's say it's deeper, and we have a high pressure alarm, where would that suggest to you that the ET tube has been dislodged to? Well, if it's a high pressure alarm, that should suggest to you that the ET tube has probably been dislodged into one of the lungs. Now we're trying to put the same amount of tidal volume into one lung instead of putting it into two lungs, so because of that we are going to have higher pressures. In contrast, if the ET tube had been dislodged and was now sitting in the esophagus, most likely we would see a low pressure alarm. Now when we talk about dealing with a high pressure alarm in flight, one of the things that we obviously lose in flight a lot of times is the ability to listen to lung sounds. Well, when we have patients who we are transporting who are mechanically ventilated, who rapidly deteriorate, we see that there's three things that commonly cause those patients to just boom, rapidly deteriorate, like almost immediately. And these three things came from some research that was done a fairly long time ago. And at the time it was done, most of our air medical transport was limited to trauma patients. So this definitely has applicability to trauma patients, to multi-system trauma patients, but you can also apply these same generalizations to some of our medical patients. So when they looked at this research on patients who rapidly deteriorated, who were mechanically ventilated in flight, these trauma patients, they found that if a patient just boom up and coded, that it was usually because of one of three things. It was either because the patient had a tension pneumothorax, because the patient had a pericardial tamponade, or because the patient was hypovolemic. So they started looking for ways to identify which is which, because obviously we don't have the ability in a loud aircraft to be able to listen to lung sounds. And they found that with all three of those presentations, we would see a very precipitous drop in the blood pressure. They also found with all three of those presentations that we would see a very dramatic increase in the heart rate. They even found that with the tension pneumothorax and the pericardial tamponade, we would actually see the CVP go up. With hypovolemia, obviously the CVP would go down. So the key to this whole thing really came to rest on the peak inspiratory pressure. Remember, if you have a patient who's having a tension pneumothorax, if the patient suddenly develops a tension pneumothorax, you are going to see a very dramatic rise in the peak inspiratory pressure. The peak inspiratory pressure is going to climb very, very quickly. In contrast, if the patient is rapidly deteriorating because of the fact that they have a tamponade, or they're deteriorating because of the fact that they have hypovolemia, that will not cause a raise in the peak inspiratory pressures, and in fact, obviously would cause a decrease in the peak inspiratory pressures. So, when we talk about the rapid assessment of high pressure, we also can look at this from another perspective. If we have the ability to look at plateau pressures can also be very, very valuable for us. So you've got an algorithm here that prevents another way of looking at patients who suddenly rapidly deteriorate on the ventilator. And I really like this little algorithm because it has the advantage of also talking about patients who rapidly deteriorate who don't have high peak inspiratory pressures, but in fact actually have low peak inspiratory pressures. So when we talk about acute deterioration in a patient who's mechanically ventilated, the big thing you always have to remember is that any patient, no matter what's wrong with them, no matter whether it's an MI or they've been shot in the head, any patient who is mechanically ventilated, who rapidly becomes unstable, who starts to literally just go down the toilet in front of you, it is always a problem between the patient and the ventilator until proven otherwise. It goes back to your ABCs. The very first thing we check is airway, breathing, circulation. Well, the ventilator is our airway and our breathing, so those are the first two things we're going to look at. Now, if the patient rapidly starts to deteriorate in front of you, if all of a sudden you see blood pressure plummets, they start looking like crap, heart rate shoots up, then the first thing we're going to go to is the peak inspiratory pressure. And we're going to ask ourselves, is the peak inspiratory pressure exactly where it was before? Is the peak inspiratory pressure lower, or is the peak inspiratory pressure higher? If the peak inspiratory pressure is lower, then that tells us that there's potentially an air leak, like i.e. the ventilator circuit has been disconnected, or the patient's ET tube cuff has been compromised, or it tells us that the patient is overbreathing the ventilator and our ventilator settings are not meeting the patient's need. Therefore, we need to do something with our ventilator settings. If the peak inspiratory pressures have not changed, then there's really only two things here that could be that we need to consider. The first one is, did the patient just throw a clot? Is the patient having a pulmonary embolus? If the answer to that is no, if we're confident that it's not a pulmonary embolus, then we know that this is probably not a thoracic process. We know this is probably not a respiratory issue. This may be an arrhythmia. This may be the fact that the patient's doing any number of things, but it's probably not an issue between the patient and the ventilator. So what if the peak inspiratory pressure was high? So if we look at the peak inspiratory pressure and it's high, then the next thing that we do is we look at the plateau pressure. And we ask ourselves, has the plateau pressure changed? If the plateau pressure has not changed, in other words, if the plateau pressure is the same as what it was before the patient started to deteriorate, then that tells us this is an airway problem. It tells us the ET tube is obstructed, the patient is bronchospasming, the patient's got secretions in their airway, the patient just threw a mucus plug. There's some kind of airway problem. In contrast, if our patient rapidly deteriorates, we look at the peak inspiratory pressure, it's shot up, so we go and we look at the plateau pressure, and it's shot up as well. That tells us this is a lung problem. This is a problem that has to do with compliance. So we need to ask ourselves things like, is the patient getting abdominal hypertension? Is the patient got asynchronous breathing and they're bucking the vent? Is the patient starting to get atelectasis? Is the patient auto-peeping? Is the patient got a pneumo, or is the patient starting to get pulmonary edema? Is this an issue with the lungs themselves? Now, what about a low pressure alarm? What if we have a low pressure alarm? Well, if we have a low pressure alarm, then the big thing we need to think of is we need to think that there's a disconnection somewhere. So where do we start? We start at the patient and work our way back towards the vent with the low pressure alarm. So starting at the patient, the first thing we ask ourselves is the ET tube still where it's supposed to be? Well, if we're using waveform capnography, we've already got that question answered probably. Assuming the ET tube is still at the appropriate depth and we've got a good square waveform, we know yes, the tube is where it's supposed to be. If we don't have waveform capnography, then we need to look at the depth of the tube. And if we are not sure that the tube is where it's supposed to be anymore, then we need to look. We need to take a laryngoscope and look and make sure the tube is where it's still supposed to be. Now, if the ET tube is good, then we need to work our way back down the circuit. We need to ask ourselves, does anything come off on the circuit? Have any things been popped off that are not supposed to be popped off? Have any tubes come undone? Anything like that? We need to look for any leaks. We need to look at our settings on once we get to the ventilator and make sure that nothing's happened, like the tidal volume hasn't inadvertently been turned down or the flow hasn't been turned down or anything like that. If that's not the case, then we need to check to make sure that the gas flow to the ventilator is still appropriate. Has there been a disconnection from the wall or something like that? And finally, if we've gone through all those things and we know it's not the airway, we know it's not the vent settings, we know it's not the pressures to the vent, then one of the last things that we might need to look at is the patient getting hypovolemic. Because remember, you have three things in your chest. You have fluid, you have air, and you have blood. Well, if I'm starting to bleed out, if I'm starting to become hypovolemic, less and less blood in the chest means more and more room for air. And as that space in the chest becomes bigger because of less blood being there, then that in of itself can cause a low pressure alarm. Now, what about if we have a low pulse ox? What if we have a low O2 sat? Well, if we have a sudden onset of a low O2 sat, the very first thing we need to look at is, again, is the ET tube where it's supposed to be? Again, we need to check, do we have the appropriate tidal volume? Do we have the appropriate rate? Do we have the appropriate inspiratory time and flow? Is our ET tube still good? And if all those answers are yes, none of those things have fallen apart, then we need to start thinking, okay, does the patient need PEEP? Does the patient need to be suctioned because of an occlusion? Does the patient have a pneumothorax? Or again, does the patient have a pulmonary embolus? Okay, let's take a break here, and when we come back, we're going to talk about non-invasive positive pressure ventilation, and then we're going to wrap up by discussing various respiratory issues that we might actually have to deal with.
Come for you, no one but you. Yes, I'd come for you, but only if you told me to. And I'd fight for you, I'd lie, it's true, give my life.